Okay, so I think we've got a few more people on, so I'll go ahead and just, as people join us, just a reminder that the CME code is in the chat room, so if you look over there, you can text that to get credit for today's Grand Rounds. Grand Rounds today is just an hour. We held off on our introductory presentations for the summer just to give everyone a little bit of a break and an opportunity to get acclimated, but we would love to resume those this fall. So if you or anyone within your area think they might want to give a brief 20-minute introductory presentation during Grand Rounds, we would love that. So just feel free to reach out to me so we can get them scheduled. Also, if you have anyone that you would like to be our keynote speaker for Grand Rounds, also please schedule. Please mute yourselves, everybody. If you're interested in speaking or have someone who you think would be a good speaker, we would love to have that for the second half of the academic year.
Yeah, I mean, I don't know if we need to copy.
Just a reminder, everyone, if you're not speaking, if you could please mute your microphones.
And then I throw it away.
I'll keep the cups and stuff in here.
And Jack, please, you can mute everybody.
Yeah, Jack does great.
You take it?
Yeah, I'll take a copy.
You want a copy?
Thank you. Okay, so once again, welcome to Johns Hopkins Physical Medicine and Rehabilitation Grand Rounds. This is August 18th, 2020, and our speaker for today is Dr. Michael Schubert. He is a I'm going to say this right? A member of the Department of Otolaryngology, Head and Neck Surgery here at Johns Hopkins. He studied, at physical therapy at Old Dominion University in Norfolk, Virginia, and got his Ph.D. for physical therapy at the University of Miami, and was a postdoctoral fellow in clinical oculomotor physiology at Emory, and then vestibular neurophysiology at Johns Hopkins University. And his talk today is Incremental VOR Adaptation, a new rehabilitative method to treat vestibular hypofunction. Oh, that's a lot. So I'm excited to hear about this. So without further ado, I welcome Dr. Michael Schubert.
Thank you, Tracy. I appreciate the opportunity to talk. That is a huge title. It took 2 lines. The talk that I'm excited to present today really reflects about 15 years of work that that our lab has been involved in. And so today I want to review the unique properties of the vestibulocular reflex. Some of the folks in attendance probably are fairly familiar with it, and a lot of folks maybe more so or not. So we'll spend a little time on the VOR and the unique properties of it and how it is modifiable. And then I thought it would be useful to discuss a little bit about the evolution of vestibular rehabilitation, because I think that as useful as vestibular rehabilitation is, we're beginning to realize there's limits to what it offers, and then sort of transition from that into this new method of adaptation that we're developing with the hopes of helping people with rehab, not just from a scientific and a neurophysiologic standpoint, of which that stuff's super exciting, but we really in our lab are interested in helping folks ultimately, as most of us are that work in clinical spaces and science. So I have no relevant or irrelevant financial relationships to disclose in the last 12 months. And I want to start off just thanking folks. This, as I said, has been about 15 years. Basically, folks from Mark Shellhammer and to your left are folks that are involved in my lab. And folks to the right of Professor Shellhammer here are out of this lab. Americo Miliaccio was here as a postdoc when I was here at Johns Hopkins as a postdoctoral fellow. And he basically took this idea from laboratory, which I had a NIH funding to develop it, and kind of turned it into what we believe is a portable and a user-friendly device. And I hope to convey that today to you. The take-home message today is that gaze instability, which by definition is an inability to see clearly during head rotation, and that is a unique sign of vestibular hypofunction. And when we say vestibular hypofunction, we're referring to the 8th cranial nerve inside the skull. And there are a unique set of exercises that have been developed over the years to treat gaze instability. And those are the unique aspects of vestibular rehabilitation. And by that, what I mean is most physical therapists and other clinicians that treat balance disorders and treat vestibular hypofunction, they know about balance. But the gaze stability exercises represent sort of the unique part of vestibular rehabilitation. I'm going to hope to convey to you that traditional vestibular rehab, which we will cover what that involves, does not appear to change the strength of the vestibulocular reflex, and that each vestibulocular reflex can be adapted separately. And what I really mean by that is the right ear and the vestibulocular reflex for rightward head rotations can be uniquely modified, separate, yet simultaneously from the left side. That's super cool, and it has relevance to clinic, which I'll convey to you. So I thought I would start with a video. This is just a brief subjective experience of someone who experienced an acute loss of balance nerve function on one side.
Ready? I'm a 53-year-old male. On Monday, June 1st at 12:30 p.m. while I was on the phone with a colleague, I experienced extreme dizziness. The dizziness persisted, and then I began to vomit, at which point I had a colleague in my office call 911, and I was taken to the emergency room where the dizziness persisted and the vomiting persisted until I was triaged and given some medicine to control the nausea.
Was there any hearing loss?
There was no hearing loss.
Any other neurological symptoms?
There were none.
Okay, so basically just saying that this is a miserable experience: vomiting, nausea, no hearing loss, no other neurological findings. Apologies for that noise. We're going to focus on one of the primary problems of having a vestibular hypofunction or a balance nerve deficit, and that is gaze instability. As I said, gaze instability is the inability to see clearly during head motion. And on the right half of your screen, this is a mock-up. This is a GoPro camera mounted on the dashboard of a vehicle and showing that the world is bouncing during vehicle motion, which is what the patients will describe to us. This also is a mock-up. This is, on the bottom, someone holding their phone and walking and then jogging. And again, it's just to show how difficult it is to see clearly during motion when you have a problem with your inner ear. This is an example of the most useful clinical test we have to identify peripheral vestibular hypofunction. And by peripheral, we mean the 8th cranial nerve and the end organ exclusively, before the afferent organ hits the brainstem. So you'll see that rotations towards the right, towards this person's right side, her eyes do not stay focused straight ahead, but for rotations towards the left, they do. So let's see if you can see that. So there, her eyes did not stay focused. She had to make a corrective eye movement back to 0 or straight ahead, but for leftward, they do. So rightward, they make a little eye movement adjustment right there. So that's the clinical test for identifying vestibular hypofunction. Its sensitivity and specificity sort of improves the more severe the lesion is. We can record that graphically, and that's illustrated here. We're going to spend more time on this plot, but what I simply want you to press upon you right now is that this is abnormal, this plot right here. This is a head velocity in black. The eye velocity does not match. The eye velocity is in red, and the red and the black should match. This is before a patient undergoes training in our lab. I don't know how to get, let me move this. It's kind of in the way, isn't it? Can you guys see that? Probably can. I don't know how to shut that down. All right, well, we'll leave it there.
The graph we see.
This is after training. The red eye velocity now matches the black head velocity. So this is before training, this is after training. So I'm going to try to convince you that this method is useful and that it works. Okay, a review of the vestibulo-ocular reflex. This is the head rotating to the left, and the eyes here move opposite the head. When the head goes back to the right, you see the eyes move to the left. This is the end organ as it sits in the skull. Green end organ is excitatory. Red end organ over here is inhibitory. And we have excitatory and inhibitory synapses that come from each labyrinth that drive the eye movement. So it's important only to realize that the eyes move opposite the head, and that is normal. I turn my head to the right, the eyes go to the left for the purpose of seeing clearly during head motion. It's analogous to our phones and when we used to have handheld cameras having anti-motion devices in them. So if your hand naturally shakes and it moves down, the field of view moves up as a counterbalance. That's what the vestibular reflex does. Shortest reflex in the body, 6 to 10 milliseconds. As you know, the static stretch reflex is about 30 to 40 milliseconds, so it's very fast. Now, how do we measure the vestibular reflex? Well, we measure it typically with this metric called gain. I will not spend too much time on this, but I just want to point out a few things. Eye velocity divided by head velocity is how we measure gain. We simply divide the head velocity, divide eye velocity by head. One is normal or ideal. In actuality, the system varies between 0.8 and 1. So roughly what that means, if I turn my head to the right at 100 degrees per second, my eyes should move to the left at least 80. If they move any less than 80 or 0.8, then there's a lesion to the nerve. We can graphically plot that. That's what's shown here. The head velocity is hard to see. It's kind of in pink here. Purple is the eye velocity. Remember, the eye velocity moves opposite the head, but the software simply inverts the trace so that we can see clearly that they match here. This is a gain that's almost ideal at 1.0. It's almost 1. Here's the abnormal side. The gain is 0.78, and you can see there's a gap. There's a space difference between the peak of the eye velocity and the peak of the head velocity. Now, we're also interested to know, and it's a little bit important to explain, that there's a difference between head acceleration and head velocity as far as the vestibular system is concerned. Now, this is an animal that is sitting in a chair that is accelerated to a constant velocity of 150 degrees per second. So imagine you sitting in the chair, and the chair moves. We hit a start button, and the chair starts to roll. It accelerates, and then it settles at a constant velocity. Because of those two different metrics, we can measure gain of the vestibular system during the acceleration and gain during the velocity. And it turns out that their recovery profiles are different, and it has rehab purposes. In a lesioned animal, so this is an animal that has intentionally had their balance nerve cut. This is the chair moving here in the stippled line, and you can see that the eye velocity, again, this is inverted trace, so normally the eye would be moving opposite the chair, but here it's been inverted so we can compare, and there's this big space here because there is a lesion. All right. So what does the lesioned VOR look like on one side? Well, it's important to note here that when you have a lesion, when we humans or animals have a lesion to one of their vestibular systems, the other side is also impaired. And that's illustrated here. So this is the side, this is a squirrel monkey whose balance nerve was cut. We can see that the eye velocity, which is the solid line, does not match the stippled head velocity and acceleration. On the other side, the contra-lesion side, we also see that this peak of the eye velocity does not match the peak of the chair, and neither does the constant velocity here. So there's a gap, and that's what's illustrated here. There's a gap difference here. After 10 days of the animal being released into their housing environment to live and move normally, we can see that the contralesional side makes an improvement, but the acceleration improves better than the velocity. The velocity here does not reach that chair velocity. On the side of the lesion, there's still a fairly significant asymmetry. So the contralesional, the good ear, so to speak, after injury experiences natural recovery that's better. But that recovery is dependent on whether you measure the gain to acceleration or velocity. So really quickly, these yellow arrows represent the healthy ear. And look at the healthy ear over days from lesion. It returns back to 1 during the acceleration component. But during the velocity component, this acceleration gain, this contralesional does not return back to normal. So the point is that when we have a lesion to one side, both sides are affected. Now, the ability to change the vestibular reflex is well known. It's been about 75 years or so of a model system to study plasticity. And one of the ways that's done is to put glasses over people or animals that either magnify or minimize the size of the world as the brain has learned it. And that's what's illustrated here. So it's a kind of a busy slide, but just to appreciate a few things. This is pre. They're the gain values for acceleration. That's this steep change in velocity. It's 1.08. And then during the constant velocity, it's 0.98. So it's very good. When we put lenses over monkeys that make the world look bigger than normal, the gain increases during both the acceleration and the velocity, but they're not similar. It increases more during the acceleration component than the velocity component. If we put lenses over a monkey that make the world look smaller than it has lived in and learned, then we can drive the gain down, and that's a little bit more symmetrical. But again, the acceleration component of the rotation responds better than the velocity component. All right. A few other ugly slides for you just to make the point that there is this unique property to motor learning in the vestibular reflex known as context specificity. And all that means is that the motor learning occurs best at the training environment. Many of the traditional studies of the VOR use sinusoidal stimulus as the training environment. So that means the animal or the human is put in a dark room, they're sitting on a chair that rotates sinusoidally, left, right, and they are wearing potentially glasses that either make the gain go up or make the gain go down. The point I want to make with this slide is that the largest training occurs at the frequency of the training. The largest gain change occurs at the frequency of the training. So let's look at this. 1 is normal or pre. Numbers above 1 mean we've tried to drive the gain up. Numbers below 1, we're trying to drive the gain lower or down. And what we can see is the greatest amount of adaptation, the highest magnitude change occurs at that frequency. This is frequency here along the x-axis. So at 0.5 hertz, we have the greatest adaptation. That's the training gain. And then it falls away from that gain. Here, the animal has been trained at 2 hertz. We have the peak at 2. Here, the peak is around 5. Here, the peak is about 8. At 10, it begins to get a little bit less. But again, the point is it tends to reduce away from the primary environment of the training. And that's important clinically. Gary Page in 1992 was one of the first researchers to look at adaptation in patient controls. I just wanted to show you this. This is gain change in both young adults older adults, and patients with unilateral nerve hypofunction, balanced nerve. And we can see that all of them change. The greatest occurs in the younger folks, and then next in the older folks. But that even the patients, the stippled line here, they also show some change. So this showed early on, relatively early, 1992, it doesn't seem like that long ago, shows that the VOR can be modified when you have a lesion. And that is important. So that was relatively fast, VOR gain adaptation. Here's the summary slide. To date, the majority of adaptations done in complete dark. It's done using whole body rotation. Again, people sitting in chairs or animals, and then being exposed to a passive rotation. It's also been done to a lesser extent with humans wearing glasses that either make the world look larger or smaller than normal. And it tends to be done at low frequencies, which are not very relevant to how we live. And so one of the things our lab wanted to address was how do these properties that we know about motor learning in the vestibular reflex, how can we translate those to real world living with the functional goals of rehab, which is to get people better while they navigate their worlds. And that is a good time, I think, a good place to introduce vestibular rehab. Terence Cawthorne was an otolaryngologist in the UK, and he noticed a couple interesting things. He noticed that folks that underwent labyrinthectomy due to Meniere's is a disease that affects the vestibular system that causes symptoms of hearing and balance dysfunction. And for the treatment still today, one of the popular treatments is to damage the ear. Now, the extent of the damage that's offered today versus back in the 40s is not as much, but the standard of care for many years was to surgically remove the end organ. So he noticed that after they surgically removed the end organ, and also in patients with traumatic brain injury, they experienced these similar symptoms, dizziness, imbalance. And he hypothesized that the root cause of this similarity between these two patient populations was the end organ, that the end organ may be the seat of damage. Now, we know now that in traumatic brain injury, people may also have a vestibular hypofunction, but most of them don't, and it's not really due to that, but the symptoms are similar. He also noticed, those of you who practice vestibular rehab will appreciate this, that anxiety must be relieved early on. He said a single member of the rehab team should be in charge and be present whenever they are seen by the surgeon. And he established this idea of prehab, which is gaining some popularity, that if you bring, what he would do is he would bring his patients who were supposed to have the surgery in a couple of weeks into the hospital for them to observe the patients who had already had the procedure doing the exercises as a form of encouragement to them. And that seemed to help them. So that developed the Cawthorne-Cooksey exercises. Cawthorne had a friend named Fred Cooksey. He asked Fred to write down the exercises and come up with this program. And the exercises were essentially based on head movement. Just turn your head, move your body, and you're going to get better. This slide, this picture just shows you the exercises. There were a lot of them, and they still are popular today. They still are used today. The Cawthorne-Cooksey exercises did help both patient populations. They noticed that the more patients moved, the greater the level of improvement. They noticed that you had to provoke symptoms to get people better. They started off gradually and then made them more progressive. And they had to just kind of repeat it with increasing velocities of movement. And that's the way vestibular rehab stayed pretty much through the 70s and 80s. There began to be studies in the 70s and 80s and early 90s showing control versus control, that if people move, they get better. Some of the issues with the Cawthorne-Cooksey exercises were, though, that they're not explicitly vestibular reflex. They were movement, which is going to engage the VOR, but they were not explicit, and they took a lot of time. If you go back and read that original literature, it was suggested that they do these exercises up to 5 hours a day, 45 minutes per session. So there's a lot of dosing questions, as you all are familiar with in rehab, and vestibular rehab is no different. We need to still sort that out. But these things involve a lot of time. And then in the 90s, vestibular rehab begins to differentiate. It was largely based on Susan Herdman. Her work, she was at Johns Hopkins. She worked closely with David Z. And David Z developed, based on his knowledge of the VOR, along with Susan Herdman, these eye and head movement exercises. And she published the first article, controlled article, showing that if you give people saccade and smooth pursuit exercises, so smooth pursuit exercises are the exercises, we test that, we give a target that moves, we ask them to follow our finger, saccade, make a quick eye movement to 2 different targets. Those were the controls. And if you gave people those exercises as control versus the experimental group that got head movement VOR specific exercises, then only the people that did those vestibular exercises had improvements in posture, gait, perception, and then dynamic visual acuity, which we'll spend some time on. So this is a pet peeve of mine, and although it's not only a pet peeve, it's now not recommended, that physical therapists should not be providing pursuit or saccade exercises. We do still see that sometimes where patients are asked to do that. There might be some other reasons to do it, but if it's for a vestibular etiology, then it's not warranted. So all of that history from 40s, Cawthorn, Cooksey, and then Susan Herdman, the differentiation of exercises, now has led to the publication of clinical practice guidelines. And Courtney Hall published that now 4 years ago. And these are the recommendations. You can read this. I won't spend a lot of time on it, but there are explicit recommendations now for folks that have 8th cranial nerve damage due to whatever reason for exercises. And the exercises are gaze stability based. That is the predominant. Now they also are given gait and balance exercises, of course, but the recommendations are strongest for gaze stability exercises. And as I said down here, it's not just my pet peeve. They explicitly state that no patient should be doing these saccades or pursuit. So these are what the exercises look like. Essentially, hold a target or look at a target, move your head left to right. That's known as the ×1 exercise. The ×2 exercises you're familiar with, both the target and the head move, but the eyes stay focused on the target. And those exercises are modified in various ways. They're based on this model of retinal slip. And this, I think this is the last slide before we go into the new method of rehab that we think might offer some advantages. This is a monkey before undergoing adaptation, sees the size of banana that it's learned through its experience, through living the world. Head moves one direction, eyes move opposite direction. That's the VOR graphically without the eye inverted trace to show how close the eye is to head. And there's no slip of the target on the retina. That is, the target stays perfectly on the fovea of the retina. The animal is given magnifying lenses that make bananas look larger than it has learned. So it makes a head rotation as it had, eye rotation moves the same, but because that banana is so large, there's a slip. The image moves on the fovea. Over time, the brain learns to generate a faster eye movement so that the image no longer slips on the fovea. So do traditional vestibular rehab exercises change the VOR gain? This is a case study that showed that it did not. This is a person doing 6 months, 15 minutes a day, using the ×1 VOR exercise. Let's look at this. This is towards the lesion side. So here's the head velocity in green. Here's the eye velocity in blue. You can see it does not match. The eye velocity does not match the green head velocity. There's the gain. 0.19. After 6 months, it changes to 0.21. It's not significant. There is a change in the waveform, right? The blue eye velocities appear to be more uniform in their presentation, but the magnitude of the strength of the reflex hasn't changed. Now, we've developed a method that can change the reflex, and I hope this video is playing. This takes 15 minutes to do, And basically what happens is the subject is wearing a laser here attached to a headband. And whenever they move their head to, in this case, the left, the target moves to the right. And they're tasked to keep their eyes on the target. But that target gradually moves faster and faster over 15 minutes. So it takes 15 minutes to do that, and it gradually moves faster and faster. This is what it looks like in the light. So the person's wearing the laser target on their head. He's turning his head to the right and to the left. And when his head turns, the target moves. And over 15 minutes, the amount of the target motion increases. Now, if we do this in the light, the brain sees the rest of the world not moving. The brain is smart. It will not be tricked. It will not change. So we have to do this in the dark. This is what it looks like in the dark. This takes about 20 minutes to train folks, so there is some training that's necessary. And what you can see is the target moves. You can't see the head moving, but the head is obviously moving. And the task is to focus on the target, and when it's dark, it's easier to do that. But early study established that when we compare this incremental technique with the ×2 technique, that the VOR learning only occurs in those folks that did the training. So we'll skip that slide. Let's look at this one. This shows retention. Two things we learned from that study. If we bring in patients and we train them to change their vestibular reflex with the traditional exercises, it changes during the training, but it's not retained. And that's what this shows. So all of the clear plots here, these cleared bar plots, are patient subjects that underwent the incremental change. This is their mean, and they all had significant improvement in their gain. These same subjects came back and did a study where they did the ×2 paradigm, and it was not retained. In fact, it got worse. So this is a review of the slide that I illustrated in the beginning, and I want you to notice two things. This is pre-training. We've already seen that the gain is lesioned here, so the red does not match the black traces. This is the score. After training, however, we normalize. It moves from 0.17 to 0.88, which matches 0.82 over here. However, notice here, we've caused a problem. We weren't smart enough to think that the healthy side also would go up. And so we kind of created a hyperfunctioning system on the good ear while we normalized the opposing side. The other thing to note is that these compensatory saccades, these sharp spikes here, are gone. There's no sharp spikes. The brain presumably no longer needs them. All right, so in summary, we've already talked about this. This busy slide just shows that if you give the brain a very gradual error signal, it learns better than if you give it a large error signal. We then wanted to know if we could adapt the vestibular reflex on one side, and that's roughly what this plot shows. This plot shows one side increasing, the other side staying the same. And then we wanted to apply that to people with unilateral loss. So that is, people have one side that's working, one side that's not. Can we drive up the abnormal side exclusively? And I'm only showing you the affected side here. This goes from 0.79. It's abnormal. It's not bad abnormal, but it classifies as being abnormal. It goes up to 1.1, a nearly 40% increase after the 15-minute training. All right, so I've shown you that we can train the VOR to these rapid impulses. We can train it on one side only, but we needed to know one other thing, and that was, you might remember that both vestibular systems get affected even though one side is lesioned, and that's illustrated here. This is the good ear. This is the bad ear. So the bad ear VOR gain 0.3. You can see this gap space between the peak of the green and the peak of the red, and these black spikes are helping the deficient vestibular waveform. Here's the healthy ear. Gain is also abnormal, also using spikes. They're just not colored black here because of the software, but this is an abnormal gain. So we wanted to know, can we simultaneously drive the right ear and the left ear uniquely? And that's what we did. We're going to skip through this protocol because it's not important and show you the results. So here's what we did. Person's wearing the laser. When they turn their head to the right, we asked that the gain go down. And when we turn their head to the left, we asked that the gain go up. So the paradigm is in 15 minutes, they're doing rightward, leftward head rotations. Looks kind of like this, right, left, right, left. They do that for 15 minutes, but when they turn their head to the right, the target is moving with them to drive the gain down. When they turn their head to the left, the target is moving away from them to drive the gain up. And that's what's illustrated here. So what's illustrated down here, just pay attention here to this green rectangle, is we went from a pre-gain of 1.02 to 1.26, 24% increase, while simultaneously driving the gain down on the other side, 1.04 to 0.82, which in this case was a 22%. So that's a single subject. This is a group of subjects showing the same thing, and essentially we can drive the gain as we want simultaneously. That was very exciting, and we published that paper. So the final part of the talk is, well, how do we bring that out of the lab into clinic? And so that's what the next few slides illustrate. We start off with some case studies. This is a patient who we gave the device and sent them home with it, and they did daily 15-minute training for 6 months, and then they had a washout period for a month, and then we tracked them at month 3 and month 6 post. All right, and that's what's shown here. So let's look at this. This is the head velocity trace before training. This is the eye velocity. You can see the deficit here. There's the gain value at 0.23. The stippled line is showing the mean saccade latency. That is the timing for these spikes to fire after the onset of the head rotation. At month 3 after daily training, it goes up a little bit. It's 0.06. It's a significant statistically. We're not sure if it's relevant yet, but the saccades go down quite a bit. Saccade latency is reducing. All right, we view that as a good thing. Month 6, the gain also has increased. It's gone from 0.23 now to 0.35, and again, the saccade latency is reducing. So we are improving gaze stability via 2 means. One, we are improving the vestibular response, which is commonly known as the vestibular slow phase here. That's this part of the waveform. That's the bell curve. It's absent here because it's not still lesion. But we're also improving the saccades occurring earlier and earlier. Then they wash out. They have 1 month now where they don't do any of this training, and the gain is the same. It does not change. In fact, I'm sorry, that's the same plot. At month 3 from this stop point, they've not changed. The gain increases. It's actually gone up. And the saccade latency has similarly gone down. And then at month 6, it's about the same. The latencies continue to improve, but the gain has changed. This is really exciting. Now, it's a case study, but in summary, what it shows is that there's retention and learning in the lesion side. So we can drive the gain up, and we can shift the saccades. We can improve gaze stability with those 2 mechanisms, and it's retained. All right, this is showing just that the saccade latency is reducing over time as the subject's doing the training, not just the gain change. All right, so then we asked, okay, you know, that those of you who treat these patients, particularly the physical therapists or the occupational therapists that may be listening, are going to want to know, well, functionally, you know, what's relevant. This is the dynamic visual acuity test over here. This is a passive implied head rotation. It's hard to see, but there's a black letter flashing on the screen. So that's passive. That's me turning a person's head. This is the active version. This is my son wearing a rate sensor attached to his head, and you can see a letter P flashing. That letter only flashes when the head moves at a certain velocity. So the test measures how clearly can you see letters during head motion. Remember, If the VOR works, then the eyes should stay stable during head rotation. If it doesn't work, they're going to move with the head. This is a plot showing that the dynamic visual acuity score is improving. This baseline here is age-matched normal. So that single black line is where we want the scores to be. And these lines are the dynamic visual acuity scores, and you can see that they're progressively getting closer to 1. They actually get normal here, and then they kind of go back up. They're better than here, but there's some variability. This is 12 months out. So this is short-term training and then tracking it for 12 months. So it does have retention. It's exciting. What about bilateral vestibular hypofunction? So we've talked about unilateral vestibular hypofunction. We had a patient come to Johns Hopkins wanting to know more about research for vestibular disorders. And he unfortunately had, in 1999, a vestibular schwannoma resection, and then 6 years later, on the healthy ear, developed a vestibular neuritis. So it caused a bilateral vestibular hypofunction. We provided him with one of these devices and trained him how to use it, and he agreed to come back and allow us to test him. And he used it for almost 2 years, not quite, 645 days. And I wanted to highlight this, and I forgot, but he reported subjectively that he felt less impaired doing ADLs, activities of daily living, and he noticed his oscillopsia was reduced. And when I asked him about that, what he said was the oscillopsia amount, the range, got less. So he still had this visual motion. It just, instead of it being this much motion, it kind of got, smaller. So that was interesting. Again, this is a case study. What's important to publish here, though, or to highlight for you guys, is the retention. In green, this green arrow represents the days of training. So 0 is day 1. He shows up in Baltimore. We measure his gains. They're not very good. They're worse on the right. The right side was the nerve section side. After training, they improved quite a bit on day 1. He comes back for day 2. It's dropped a little bit on the right side. Then we sent it home. We gave it to him. He did not train. He stayed with us for a week. On day 3, day 4, day 7, we didn't do any training. We just measured the gain. And we see that there's a little bit of a slow creeping up here that's going on. Then we send him home. He comes back at day 479, day 645, and these are the values. So they're not normal, but they're a lot better than these values, and they looks like they lead to subjective change. Objectively, we measured his balance. He had a change in his medial lateral sway. So this is a little bit hard to appreciate, but this magnitude of sway here, this is pre, and this is after 1 day of training. This is after day 479. Both 1 day and 479 are significantly less sway than pre. This is the setup. Each of these red circles represents an inertial measurement unit, so he's wearing these trackers, and we're asking him to walk. There was no change in the velocity of his ankle moving forward, something else we looked at. So he had change in ML sway. That was published in this case. And then we looked at his ability to stand quietly on a foam surface, sort of a classic clinical Romberg test. And you can see that whether we measured from the head, trunk, pelvis, left or right ankle, that pre-adaptation is much larger than the 1 day or the 479 days. So again, it looks like this training method does lead to retention. Now, case studies, not controlled. This is now our first clinical trial. These are early results of the clinical trial. There's a couple slides left in the presentation, so I hope you're still awake. This is 24 patients with chronic peripheral end organ, 8th nerve, or the labyrinth damaged, that were assigned to either intervention or control. The control group did ×1 VOR exercise. Again, that's looking at a target, turning head left, right, once a day for 5 days, 15 minutes long. The intervention group used that equipment, turned their head and the target moves a little bit, that gradually increases over 15 minutes for 5 days. And what we found was that the VOR gain significantly increased only in the intervention group, not in the ×1 group. And it increased whether the subject moved their head or we moved their head. And that's important because remember, when we train folks, they are actively turning their head. When we measure them, we tend to do it passively. So there's a difference there. This is the plot. It's a little bit busy. This is the control day 1. So day 1, the gain is 0.46. I know you can't see that. I apologize. You'll have to trust me on that. This is day 5. The gain drops to 0.31. We think that's a significant drop in gain. It goes down. For the intervention group, it's 0.23. Wouldn't you know it that in this particular subject, the gain initially was much lower in the intervention group, this person, than it was in this control. But it went up to 0.52, significant change. And you can see that there's less white space here than there is here, suggesting that the gain is better. The other thing to notice was interesting, and that was at day 5, the control group were more reliant on these saccades. That is, do you see this stippled line? This stippled line shifts earlier at day 5 in the control group. But in the intervention, this stippled line shifts later. Okay? So when we can drive the gain up, when we can improve the gain, we don't need saccades as much. So this is interesting. This is suggesting that the traditional rehab might lead to the recruitment of saccades, but it doesn't change gain. Whereas this new method leads to improving the gain, less reliance on the saccades. All right, now that's a 1-week short-term trial. All right, what about dynamic visual acuity? Dynamic visual acuity improved in both. DVA got better both when they moved their head actively and when they moved their head passively. And what about fall risk, balance, gait, and then perception of handicap? Perception of handicap is a subjective test known as the Dizziness Handicap Inventory. So DGI scores statistically improved for both groups, but only the incremental group or the experimental group did it normalize. Only the incremental group had increased gait speed and step length, and that's shown down here. This is day 1. We see the step length here that goes from the heel to heel. That's step length there. And heel to heel here is larger. All right. Also, the sway area in the incremental group reduced significantly where it did not in the control group. And then interesting that the control group had a reduction in gait speed by greater than the current accepted meaningful clinical important difference. And then DHI also improved only in the group with the incremental paradigm. So that's our first controlled trial to suggest that incremental does help improve the gain, but also lead to some functionally relevant changes, which are frankly probably more important to the patient: better balance, better clarity of vision during head rotation. But in conclusion, each vestibular reflex can be modified separately yet simultaneously. So the brain contains the circuitry to be able to handle that kind of asymmetric adaptation. Secondly, active training using this incremental method leads to both active and passive training. So we can train them actively, but when we measure them, passive or active, there's improvement. So that suggests that the motor learning is robust. And there's early evidence that this method can improve gain, but also dynamic visual acuity and balance. I'm not sure if you guys can see this or not, but this is one of those optical illusions. It's a stress sensor, and if it's moving, you are stressed, and if it's still, you are calm. So I hope it's still for you. And that's it. Thank you very much for your listening.
Thank you, Michael. This is
I'm happy to entertain any questions if you have them.
this is Pablo Salnik. I don't know if you can hear me, but I really appreciate the talk.
I think sorry, Pablo, I turned off my sound. Sorry, say that again.
Now, can you hear me?
Yes, thank you.
Excellent. So I was just saying, imagine everybody clapping right now.
Yeah.
And cheering for the presentation, something that we like with Zoom. But I thank you for the great talk. I think I really appreciate the conversation, and I want to make a couple of comments and then a question.
Yeah, absolutely.
So first is great work, and I appreciate the clarity of the presentation, and the comment is for others to hear how understanding basic mechanisms of brain function or neurophysiology can drive to improve the training paradigms that we employ with our patients and drive rehabilitation. So this is something that I always wave the flag on my space about the idea of understanding the mechanisms of this function allows us to design better training strategies. And your talk, basically, you're talking about that in the space of the vestibular reflex and balance. So I appreciate very much that. The question, so I have one is from my point of ignorance. You clearly say, well, if you do the traditional rehab, you get improvement. People maybe you were hinting compensated by saccades instead of improving the gain. So why we need to bother moving with the gain instead of saccades? What are the pros and cons of the two?
Yeah, it's a good point, and I get that it's a comment that I get asked, and I also get asked the alternate well, sort of a similar, which is, well, they get better. Why do you have to do gain training? And so it's kind of a two-part answer, I think. One part is we don't yet know how gain change really might be better. The gain is the signal of the problem. So at least intuitively, I think it makes sense that if you can repair the problem, you're going to fix the symptoms of it. So that's one sort of basic response. Whether or not saccades or VOR gain lead to improved function, we're not savvy enough yet to know. So it's a little bit of a reach for me to say that vestibular rehab looks like it says it improves saccades, although that is what we found, that the latency of those saccades reduced, and that the incremental method drives the gain up, and we don't therefore need the saccades. The reality is there's a threshold where the VOR gain, once it gets damaged, then the brain has to recruit a saccade to help it. And so even in those folks where the gain went up, there are still saccades, because we've not essentially improved the gain enough to eliminate them, at least based on the short-term study, which was only a week. Right. We're doing long-term studies now, so that's probably going to be different. Right. So I think that's the answer. The goal is gaze stability, and whether the brain does it through a saccade mechanism or a VOR mechanism, I don't think it probably cares. And we have seen that if we drive the gain with the incremental method really hard, we can also recruit those saccades. So I think, again, the goal is gaze stability. And it's interesting to look at the oculomotor differences, but in the end, function's the important part, I think, and the brain might not care.
Right.
Yeah.
So I appreciate that distinction. And quick follow-up. I was curious, you show an example where you do training for a couple of days, but then you stop doing the training and the patient continues improving over time. So what do you think may be going on there?
Yeah, we've seen this a couple. That's a great comment, and I can only hypothesize that we've trained the brain to use retinal slip that they constantly must be experiencing to now enhance the learning, right? Because the VOR doesn't work. These folks are walking around. They're getting all kinds of error signal, right? It's not working. They turn their head one direction. The eyes don't move like they should. That creates retinal slip, but it doesn't lead to change. you might argue and expect that, well, that normal experience of retinal slip that they experience just because they have a lesion should self-correct and cause the motor learning, but it doesn't. But once we train them, and we train them with these gradual error, then it seems like the brain is able to both remember that and make effort towards learning, and then bump it up a little bit. That's the best I can do, Pablo. I mean, it's really fascinating to think that we didn't measure them for out to 6 months, and it still was kind of creeping up a little bit.
It reminds me a little bit, we discussed some of the things in other domains, in the other motor domains, where maybe patients have, a locus minima around behavior, and not exploring something else. Your answer reminds me of this idea of there's the locus minima where the person behaves, and but it's not exploring, going beyond that space or that locus minima. But once you put them out there, then there may be some other reinforced mechanisms that kick in that then continue to drive.
Yeah, I like that. I'm gonna offline send you an email. And have you published that? That's a great thought. That's a great explanation potentially.
I think I'm just putting words to what you were describing earlier. I think people, and I think there's some other folks on the Zoom today that they work. Some of these we discussed with Amy and Brian Romick and others in the lab when we talk about gait, but also in the upper extremity, and this concept of pushing the person to do a behavior in a completely different way that otherwise cannot be solved. So happy to continue that conversation.
It's really fascinating. We didn't expect it at all, and we've seen it now in bilateral, unilateral. We've seen it as a group, kind of as a group as well. So it's something legitimate there.
Yeah, great.
Yeah.
Maybe others have questions or comments. And if you do, you need to unmute yourself. Okay. Michael, really, again, I appreciate the conversation. I don't know if folks want to jump in, they can interrupt me, but this is one of the problems with Zoom that it's hard to tell there's no raising hands. But I really appreciate the conversation, and I know this is a very important work, and I know that you manage a very important lab and an area of rehabilitation that has helped a lot of my own personal friends and patients. And
yeah, thank you. That's very kind. Yeah, I've got I got some of your folks in my lab, and they're great. Jen Miller and some other folks that are kind of interested. So if I can get some more funding, I'm going to grab more of your folks from you and get their expertise. But I appreciate the opportunity. Absolutely.
Great. Thank you.
Thank you so much.
All right, you guys take care.
All right.
Bye-bye.